Now we would like to welcome Dr. James Paton, Reader in Pediatric Respiratory Medicine, School of Medicine, College of Medical Veterinary and Life Science, University of Glasgow. He is a senior lecturer in pediatric respiratory disease at the University of Glasgow, based at Royal Hospital for Sick Children, Glasgow since 1989, and a reader since 2003. He is qualified in Glasgow, but spent a good part of his postgraduate training in pediatric and in Edinburgh and Leicester. He is currently one of 5 specialist pediatric respiratory consultant in the west of Scotland, based at the Royal Hospital for Sick Children in Glasgow. He is the lead clinician for children with severe asthma, runs a difficult to control asthma clinic that sees cases from across the west of Scotland. He is currently the clinical lead for the West of Scotland Complex Pediatric Respiratory Network. His main current research interests are the health services research in pediatric asthma care and physical activity in young children in relation to health disease.
Thank you for the introduction. Thank you for asking me to speak again. I think this is a more challenging talk than yesterday about croup. So what I want to think today is about whether we should be using or not using antibiotics. You might think, I think, if you saw the slide from the WHO pointing out that pneumonia was the captain of the men of death, if you like, in children, a leading cause. I put the 2 top there. You can see in neonates and pneumonia in the 1 to 5-year-old children, pneumonia accounts for 13% of death. There's a large number of deaths each year. And there are many episodes that result in hospitalization throughout the world. That's true in my own country. And they point out that in the less developed countries, many children actually die before they get to hospital. With that background, I think you'd wonder why something like this is actually of great relevance. But I think you'll all know that there is increasing concern about antibiotic resistance. You'll notice there that there was a World Antibiotic Resistance Day on 16th November, and in fact in my own hospital, I was stopped as I went through the hospital by one of the microbiologists who wanted me to sign up as an antibiotic guardian because of the concerns about antibiotic resistance. And certainly in the United Kingdom, that's becoming a very big issue indeed. What causes antibiotic resistance? You'll know that it's issues such as inappropriate use by the patients and inappropriate prescribing. It's interesting, you'll probably know there was a large randomized controlled trial in non-severe pneumonia in Pakistan where they compared 3-day amoxil with 5-day amoxil and they were equivalent. The interesting point from it was that failure in the 3-day amoxil regime was most associated with non-compliance, which resulted in longer use of antibiotics and more complications. So non-compliance, I think, is an issue for everybody. Inappropriate prescribing, I think what I want to concentrate on today is where we should be using antibiotics, but it's just useful to highlight to you some of the problems that we encounter. This is data from the United Kingdom. We had a big national pneumonia audit where for 3 months we asked people to submit all the cases, data on all the cases of childhood pneumonia that they had. It's a large sample, you see 1,500 cases, and you can see there the range of antibiotics that were used in the United Kingdom for pneumonia. And you would have to say it's much too large. If we just move on, though, to thinking about the diagnosis of pneumonia, you'll know that I think a very significant advance was the WHO in the 1980s, developing their classification of acute respiratory infection in children with cough and/or difficulty breathing. They divided it into a number of categories, separated by the respiratory rate and by the presence or absence of indrawing, and for very severe disease, a number of additional signs. That was a very important advance because it, I think, allowed more simple clinical diagnosis of those children who were likely to be at high risk of pneumonia. The gold standard they apparently used for developing that was clinician diagnosis of pneumonia. When they revisited that around 2010, they pulled a panel together, and the panel reviewed the pathogens that cause pneumonia. There's a whole series of studies available from different countries with different problems, such as HIV, whether they're more developed or less developed. They estimated overall that bacterial infection was responsible for maybe 20 to 50% of the cases, and viral infections were also a very significant problem, as you know. And of course, through this time, what's been going on in the background is the introduction of new vaccines for Haemophilus influenza and for against Streptococcus pneumonia, which is changing the picture. Because of concerns about resistance, they changed the criteria and they shifted from using cotrimoxazole to suggesting oral amoxicillin. And you'll know that a 3-day course of oral amoxicillin is something that would be recommended. Now, if we just take some of the issues around that, there's been work looking at the concern about the WHO standards as perhaps being leading to too many diagnoses of pneumonia that result in prescription of antibiotics. And one of the first problems that the literature points out, that there's a problem with the diagnostic gold standard for childhood pneumonia. That is, when do we absolutely know that we're dealing with a case of pneumonia? And when you review the literature, you can see there that actually the standards have, when they've been trying to work out what tests they should use, they've used a number of gold standards to work out whether they thought the child had pneumonia. Blood cultures, looking for clearly bacterial infection, or chest x-rays are particularly common, but other things have been needed. Notice the conclusion: a critical need for experts in childhood pneumonia to develop an accepted gold standard. That is, how do we definitely know that we're dealing with pneumonia? And it's interesting, this Lancet paper took the WHO standards and then looked for studies that compared these standards against chest x-ray as the gold standard. So a chest x-ray saying you had pneumonia, how did the clinical signs that would go into the WHO score measure up? Notice there's symptoms here and then signs, and concentrate on the columns for sensitivity and specificity. So cough is clearly a highly sensitive marker of whether you have a respiratory illness, a lower respiratory tract infection, pneumonia, but it's not specific. Difficulty breathing is slightly less sensitive, but is also not terribly specific. If you go to some of the signs that would be important in the WHO score, notice there that actually they also have, their sensitivities are perhaps not too bad, but their specificities are less good. So our clinical signs for recognizing pneumonia don't actually work terribly well. There was a very interesting large trial that I've told you about in Pakistan where they compared 3 days and 5 days of amoxicillin for children who met the criteria for non-severe lower respiratory infection pneumonia, and the result was that 3 and 5 days were the same. But the interesting thing is that they reviewed the x-rays, and they had many x-rays in the large series, and put them through experts to see in these children, in the 2,000 children that were recruited, who were supposed to have pneumonia on the basis of the WHO criteria, how many of them actually had pneumonia on the x-rays. Notice radiological evidence of pneumonia was only present in 14%. Bronchiolitis in 4%, and 82% at normal chest x-rays. So we are clearly over-diagnosing pneumonia with these criteria. And of course, that doesn't help us with the etiology. How do we decide whether we're going to use antibiotics or not? This is the common picture that we're all faced with in respiratory medicine. Which of these children who has changes on their x-rays which one needs an antibiotic? And if I show you the organisms that were isolated from these things, I don't think you would have guessed exactly. And that's the point, I think. This particular paper showed that bacterial infection was highly probable in those with alveolar infiltrates. It's quite difficult, I think, to focus entirely on which children had alveolar infiltrates. But because it was difficult to sort it out, it's virtually impossible to distinguish whether it's viral or bacteria, and therefore you have to treat everybody. So using X-rays to help us get to an etiological answer as to whether you need an antibiotic or not is not proving very useful. And of course that culminated in, I think, what's an extremely brave and interesting study from Pakistan, where they did a randomized double-blind controlled trial of placebo versus amoxil in non-severe pneumonia. It's a large study recruiting many children, and you'll notice that at the end of the day, there was no difference between those children treated with an antibiotic or a placebo. If you look at some of the data, I think you'll start to maybe see why. I've just picked out here those children that are presenting with wheezing from the data, the therapy success and therapy failure, and signs on examination of wheezing. And clearly wheezing is often associated with fast breathing, but it's not included in the diagnostic criteria. And if you look at that wheezing by age, you'll see a substantial proportion of children below 1 year of age have wheezing present. And I think looking at that data, you would say to yourself, actually these children don't have a bacterial lower respiratory infection. What these children have got is bronchiolitis. And sorting that out is clearly problematic. In terms of looking at what are the organisms which are causing diseases today, I think this New England Journal of Medicine study stands out. They used molecular studies for picking up the viruses, and they used molecular studies on blood and pleural fluid if they had it to pick up bacteria, and they also cultured for bacteria. So this I think is a comprehensive attempt to try and get to the cause. This was a prospective study over a number of years in the southern United States, and notice they picked out children. The aim was to look at what was the etiology of pneumonia. So we have children with evidence of pneumonia, and now we're trying to sort out what the cause of the pneumonia is. And you'll recognize, I think, many of the children the sort of problems and age distribution you would expect. And then if you look at the top slide, you'll see in the light gray, there's a proportion where they get no pathogen at all, and the most pathogens are viral pathogens with the dark blue slides. But there are co-infections with viruses, which I think we see not uncommonly, and there are co-infections with viruses and bacteria, which again you occasionally see. And if you look at the bottom, notice that as you go across, the commonest pathogen detected is respiratory syncytial virus. So the dark bars are pure single monopathogens, the lighter bars are combinations of pathogens in each case. And notice as you go towards the end that strep pneumonia, where an antibiotic would be useful, is now quite an uncommon cause of pneumonia in that part of the world. Clearly what we need is similar studies from around the world to characterize the particular populations that people are dealing with in their areas. What's the way forward for childhood pneumonia? Well, can we recognize pneumonia better? There are some tools clearly that have become available that have not been included in the WHO algorithms up to date, and oxygen saturation would be the obvious one. And this paper showed that that oxygen saturation measurements were a better clinical predictor for pediatric pneumonia. So that's deciding whether you've got pneumonia, making that diagnosis more specific in the first case than the available clinical criteria that we've shown are not very specific. The second thing I think that is clearly recognized is the need for better rapid diagnostics. This is immunofluorescence for RSV infection, which we actually used for many years. It takes about 10 minutes for a child presenting in the emergency department to get a fluorescent antibody test, which will give you a pretty good result as to whether RSV is present or not. In fact, we've moved away from using this test, and now what we're being given is molecular testing, where they characterize a whole range of viruses. But there are some problems with molecular tests. First of all, they're less good just now for detecting bacteria. And secondly, they can detect viruses very sensitively even beyond the time when the virus has been pathogenic. So the virus could be still there, but is not causing illness anymore. This is a Swedish study which was looking at community-acquired pneumonia, particularly in children, and you can see the range of viruses that they got in the cases, but notice also that some of these viruses were also very common in their controls. So better diagnostics are needed. The WHO suggests that the way forward for us is that, first of all, we need better guidelines for assessment and management. We have to be able to recognize children with pneumonia, I think, more specifically than we've been doing up till now. There's clearly an issue in many parts of the world about access to hospital care for severe pneumonia, and the development and provision of oxygen has been one of the key things that people bring out as an important component of many managements. And we clearly need improved diagnostic methods. I think we need things that are cheap and fast and accurate, and we don't have them yet, and that's clearly got to be a focus for what we're going to do proper in the future. And that hopefully will allow us to get a more focused and appropriate use of antibiotics so that we can target them on those children who actually would benefit from them. And that's going to be an issue for us if resistance to antibiotics is going to become a really serious problem. And clearly, one of the issues that probably has contributed towards where we are today is the fact that we've developed effective vaccines for some of the bacterial illnesses. So they're being taken out of the equation. And what is actually causing pneumonia is shifting for us now, and it looks as though the viruses are becoming more important. And clearly there's other issues. I would pick out specifically something that they touched on yesterday, which was the issue of exposure to passive smoking as being a very important issue in terms of avoiding in children. So where do you get to at the end of the day? Well, I think the answer is actually there isn't an easy answer. Of course we will use antibiotics in children who we think have got pneumonia because while we're recognizing that there are problems around this, we don't yet have the tools and the algorithms that allow us to focus down the problem and restrict our antibiotic use just now. So I think the problem is actually getting harder rather than easier. Thank you very much.
Any questions?
Stop X-raying them. It's quite interesting. We did a study in children with asthma, and I just use that as it's very clear in bronchiolitis there is no requirement for an X-ray. I'll just give you an example of asthma. We did an audit of our asthma, of children admitted with asthma, and at the time a proportion of them were getting X-rayed. The estimate is about 5% of children need an X-ray who come in with asthma. We were X-raying 25 to 30%. When the X-rays were interpreted by our junior staff, it was effectively like, compared with what the experts said, it was effectively like tossing a coin. So basically, if they put the X-ray up and they said, is it abnormal or not, they might as well have tossed a coin. Choom. If it came down heads, that is, they interpreted the X-ray as positive. It's exactly like you said. The consequence was they prescribed antibiotics. So the answer is, stop them X-raying the people, and then they won't have the same drive to prescribe the antibiotics. And it won't do the children any harm at all. And that's true of bronchiolitis. So most of our children now go into a nurse-led bronchiolitis pathway. We try and diagnose bronchiolitis based on the clinical presentation, plus or minus screening during the height of the epidemic, and those children in general would not be X-rayed. And that stops us, or it helps us to follow the advice, which is don't give them antibiotics. So there are strategies I think you can use for that.
So, Dr. Paton, over here. Thank you very much for the excellent presentation. I just have want to ask you your thoughts about treating aspiration in pneumonias in infants especially. And does that differ between a teething baby or non-teething baby?
Well, I think most cases of aspiration are going to occur in specific circumstances. So the child is going to have other comorbidities that make aspiration likely. So various handicapping conditions. Or the child is going to be in hospital and there's been an issue that's led to aspiration. I think apart from that, if you're dealing with a normal child coming along, aspiration is likely to be a very uncommon problem for you. And I think the issue for aspiration as for pneumonia is I think we're not at all good at recognizing when an aspiration injury has occurred to the lungs. So we don't have good specific diagnostic tests that allow us to recognize this is an aspiration. Clearly, if you did recognize it as an aspiration, then usually the advice would be you would be managing it with a broader range antibiotic because of the concerns about gram-negatives and the other things. But I think unless you're dealing with other comorbidities, it's not a common problem to have to deal with.
About CRP, can differentiate between the NG and the viral?
No, I don't think there's any, of the markers. I think it looks as though procalcitonin is coming out better, but they do not distinguish between bacterial or viruses in a reliable way. And again, I think stopping people measuring it is probably the most useful thing you could do.
Okay, thank you,
Thank you
Dr.
very
James.
much.